Good morning, everybody. It's amazing to see all of you here on a Saturday morning. I really have to thank all of you for coming down to join us here in NUS Medicine's Data Demo Day. I'm your MC for today, so I'm Zachary. I am both a clinician as well as running this program. So I have 3 jobs. So one of it is actually running this program with my dear co-director, Lowell. Also in the emergency physician in resident physician in Alexandra Hospital, but also working in innovation office in NUHS. The main thing is actually on behalf of Prof. Chong Yap Singh, I think the Dean of NUS Medicine, who regrettably can't be here today, we would like to thank all of you for coming down and supporting this space. This actually originated as an idea with both me and Lowell, like basically at the start of this year about building startups and improving the ecosystem. And I mean, looking out today, like I have to say, like really thank you, and really we've done it. You see, it was an amazing idea that we came up, seeing so many familiar faces, YE from Microsoft, people from Kern, the many mentors that kind of partner us through this program, who devoted their time, their Saturdays, huge part of the ecosystem to kind of helping these startups grow and be where they are today. Anna as well. Oh yes, amazing internal teaching. I think a large part of it was originated from the idea of, can we actually build startups from a hackathon? This is not a new idea. Hackathons are not a new idea by any way, but how can we actually foster greater innovation and cross-pollination among both tech and medicine in this space? How do we encourage this? Because we do care about our patients and we need further growth in this space. It's not solely one stakeholder, because healthcare innovation is multi-stakeholders, and it's how do you encourage this growth rather than being segregated. I think when we did, and both me and Lowell had this pitch when we organized with Microsoft, we had this vision in mind. And I think what Singapore actually, I would say Singapore as a whole, it responded in a way that we never expected by having like 1,200 participants. Because that was just blew our minds, because it was a 2-man team at that point in time, and we were trying to organize a hackathon for 1,200 people. That was just a bit bizarre and crazy. But I think that showed us that there's actually a demand or a need for this space, and to how do we encourage and foster more of this. I think from there, we are very, very proud and very happy that one of the winners of HealthFact actually are here with us today. They're actually one of the most amazing startups that I'm so proud, and thank you for trusting in us. Marymount Labs, you'll hear more from them as well. They have built amazing product and pivoted multiple times. It's also to highlight all the different mentors who have taken their time. And of course, our partners, 22 Health Ventures. I think this is so serendipitous. I think we met Paul at the start of this year, exactly in this LT. I think this is when HealthX Finals were coming about. How do we kind of encourage more of the ecosystem and give pre-seed funding to startups, like encouraging them to take the plunge and do amazing work in the Singapore healthcare system. And I think this is the result of all this. We thank you all for taking the time to spend with us. Now, I think we're going to focus now on the main stars of the show, which is the startups. And after that, first a word from our dear partners, Paul from 22 Health Ventures. Yeah.
Okay, so my name is Paul Shabetta. I'm the co-founder and managing partner of 22 Health Ventures. We are, as many of you know, an early stage health technology venture capital investment business designed from day one to contribute to and to capitalize on Singapore as a global leader in health technology and the gateway to Asia for health technology for decades to come. That is why we exist. I want to just take a minute to underscore why I think this moment is important that we're doing here together and the serendipitous opportunities that we've been creating this year. And I'll do it in a couple of statistics that I always say and are the reason that I have relocated to Singapore. Number one, do you know that in the United States of America today, already, more than 75% of the public market stock value in the country, almost 80%, is from venture capital-backed startups. 92% of the R&D in the United States of America today is from venture capital-backed startups. The United States is a venture capital-backed startups country, and that's coming here. So Singapore has achieved more in the last 50 years than probably any country in the world. But the muscles that it built to achieve the amazing things that Singapore has achieved in the last 50 years were muscles that are related to real estate and manufacturing and logistics and financial services. Those muscles are different from the muscles that you need to be able to produce startups. So we here today, this community, is the beginning of the next 25 years where we need to build the key muscles you need to succeed at startups. Because a decade from now, Singapore's economy will be increasingly dependent on success in startups. And that starts kind of now, within healthcare, especially in our world. Okay, so startup innovation is basically about building and maintaining a collaborative ecosystem for founders. So I want to start today by just acknowledging the real pioneers of this program, which is the founders that are in the program. Those founders, 10 years from now, we need them to be walking around, having succeeded and showing other people what's possible. They are the ones whose successes should be remembered. Their successes will be our successes. So we honor you guys. You are the pioneers here in the first year of this program, and no pressure, but please don't screw it up because the rest of the economy depends on you. Okay, so beyond that, the rest of us, we're that collaborative ecosystem. We have a great responsibility to build something that is hard to build and takes each of us to be creative and courageous in how we support these founders. It is the coolest thing in one of the biggest opportunities that you could ever be involved in the world today. Okay, so I would like to start by thanking my partners in NUS Medicine. The serendipitous meeting of them was so perfect, so perfectly timed. Zach, Lowell, Aristotle, Prof. Chong, and the whole gang has been, this thing here is a startup. I've watched them with such conviction build this program, and it is an honor to be NUS Medicine's partner in the launch of the NUS Medicine Data Program. Okay. I want to really thank all of the mentors we have gotten such great feedback from all of the mentors who contributed to these founders. And this couldn't have happened without you. Many of you are my friends, but I just want to say thank you for your generosity, thank you for your time. The advisors as well, whether you're a fancy professor at NUS who walked over or whether you're one of these weirdo Americans who flew 20 hours to come over. The advisors also, I think, really contributed to making this something that was kind of unexpected and unique in its kind of entrepreneurial feel as it went through the program itself. So thank you so much to the advisors. And then finally, I want to say to the community here, so we're now I look forward to hearing the pitches of all of our great founders through the program. I encourage you by the end of the day to overcome any shyness you have. Everybody should know these founders by the end of the day today, because that is our responsibility to build the ecosystem around support for these founders who have the hardest job of all of us to build great startups for our future. Thank you.
Thank you, Paul.
So I think we'll go to the meat of the show, which is actually the startup showcase itself. I think the first startup we're going to showcase is actually TenangAI. It's actually, for our first cohort, they are actually an Indonesian-based startup that actually flies in every 2 weeks to be part of our program. I think it's been amazing getting to know Salma and her team and the progress they've been making. So I think I'll just leave them to kind of share a bit more. Yeah, so Salma, please.
Hello, everyone. Imagine when you are Gen Z, feeling anxious, daily stress, every day, and no one can help you.
As a psychologist for 5 years, yes, I can confirm that Gen Z becoming more aware of their mental health, and they try to seek help even before things get worse. But you know what? In Indonesia, we only have less than 3,000 psychologists for the whole 100 million population of Gen Z. Is it enough? Of course it's not. But you don't have to worry, because that is why we are here creating Nasia, an empathetic AI co-psychologist. You can see here how Nasia are actually helping Gen Z. Finally, with the help of Nasia, now every Gen Z and millennials can get the mental health support whenever they need it, including at midnight, in a very much affordable price. And here's another good news. Nasia is more than just a chatbot. It is a combination between generative AI and a psychological testing like CBT and DBT to make sure that Gen Z can feel better and get insight out of their mental health. And our technology is also built with our own very proprietary data to ensure that they can chat with Nasia even in their own daily language. How about data privacy? We ensure that it is safe because we are the one and only AI mental health in Southeast Asia with HIPAA compliant.
In Indonesia, we have a good positioning as the one and only AI mental health to help Gen Z's and millennials' mental health. By this credible recognition by media, we already help 50,000 Gen Z's and millennials all around Indonesia from 37 provinces. With the very good unit economics, this is the very big opportunities for the good business in the future. But the main thing is, the 40% of them are students, and 50% of them are employees. And this is the main reason we expand our business from B2C to B2B2C to aim 15 billion US dollar, the TAM, and we start from the sum in Indonesia, 150 million US dollar. And you know what? We already serve the leading organization in Indonesia. We help the biggest Muslim university to taking care 23,000 students for high school, and we help 2 government cities in Indonesia. One of them is Jakarta, to help government help Gen Z's mental health citizen immediately. And you know what? We have a good strategy, go-to-market strategy, to make sure that we serve the Gen Z and millennials all around the world. The first is social media, when the Gen Z and millennials are. The second is government. In Indonesia, if you want, you go big for startup, partnership with government. And the third is event and communities. This is not for Indonesia. We bring impact to the world, Europe, Southeast Asia, Australia. This is just a beginning for revolutionize mental health for the world.
And we believe that TenangAI is built by a passionate and experienced team with me as a psychologist of a subject matter expertise, supported with an AI engineer and experienced business operation. We're also supported with a global board of advisors to make sure that we have a global quality of product. And now, this is a very good opportunity for all of us because we are raising for $2 million funding to accelerate our RRR of 500K, build enthusiasts for SaaS and API, and also market expansion to Southeast Asia.
TenangAI is not just a business. It's a commitment to taking care the next generation by relevant technology. Thank you.
Thank you so much, Salma and Andy.
And happy to answer your question.
Yeah, so I think we have 5 minutes. If anyone from the audience have any questions, I think they can raise their hands. We have a mic runner to kind of let you basically fill your questions, or if you are able to project your voice, very happy to hear them as well. Yeah, I think.
Yes.
My question, my background is I'm a cardiologist, but I have mental health doctorate in medicine from the UK. The work that you're doing is very much needed now with all the gloom and doom in the world. How do you ensure the safety of medicines when you put in your psychology AI in place? Because mental health patients have would be taking antidepressants and antipsychotic drugs. And how do you ensure the safety of medicines, and how do you do that?
Okay, thank you for the question. First of all, we'd like to a bit clarify that we are focusing more on the low to medium day stress of the mental health condition. So if I can give you like a spectrum of mental health condition from 1 to 10, we focus on a 1 to 5 scale. So it's more on a daily basis stress. So when the AI actually detected that these persons actually have a more severe cases, we will have the psychologist in the loop to actually help them with that. That's why we were not focusing more on the severe, but more into daily stress. I hope it helps. Thank you.
Thank you. Very nice presentation. Very good idea. So how are you doing this with languages? I see this is in English. So two things. So Bahasa versus English, but also you're targeting Gen Z specifically. And I have to say I don't understand everything they are saying. So are you also incorporating that slang, for example?
Okay. Yes, thank you for the question. So that is why I mentioned that we have our very own proprietary telehealth data coming from the conversation between the psychologists and the users that is built in Bahasa. That is why we use that data to fine-tune and train the AI so that it can understand better on the relevant language. Even it can understand if it's a mixed language between English and Bahasa. And the reason why we targeting Gen Z, mainly because they are more aware of mental health and they want immediate help. And the way that we incorporated that is in the message, in the language. That's why it can even understands emoji, slang language, basically their daily language. So that's how they will feel like they are talking to like a person instead of a chatbot. Thank you.
So as you're moving from a B2C to B2B2C, yes, how would your revenue or subscription-based model change or evolve?
Okay. I think in terms of revenue from B2C to B2B2C, it doesn't change much. For the B2B2C, we are focusing more on an annual subscription, also affiliate partnership. So so the schools or the university subscribes to us annually for session. For example, here the university subscribe annually for 500 session per month, for example, or a certain number of session depends on the demands and the scale of the big of the university and school. So that's the difference of the revenue base. While on the B2C side, we are on a monthly and a daily subscription. Thank you.
Thank you. I like this slide because I see all the numbers, but could you tell us on an average how many of them are going back to your app? Let's say like are they 5 times or is it 10 times so that you can test the utilization and the fact that people are using your app?
This is the interesting part about the interactions of Gen Z with Nisha is that because it's so easy and fast, they come back at least 3 or 4 times in a day. So for example, they talk to Nisha in the morning saying that I cannot get up from school because it's so stressful today. And then in the middle of the day, they come back again telling their stories. And then at night, they come back again. So that's why the retention of the users per month can be like 30 or 40%. So that's how the utilization actually goes up. And the average minutes of they spending per session is about 18 to 20 minutes. So it's not that long, but they're coming back at least every day and every couple of weeks. So that's how. Thank you.
I think we have run out of time for questions. So I think do catch them after for the networking session if you have further questions for TenangAI. So I think give them a round of applause and thank them for their effort. Thank you so much. So I think now moving forward, we are actually moving from Indonesia now to Vietnam and Australia. So I think this is Dr. Nelson Lau. He's actually a physician by training, and I think he's built an amazing product for himself because he feels that there's a huge need in the healthcare space and he's gaining traction quite a fair bit in Australia. So I think we'll leave it up to him to share a bit more.
Hello everybody, I'm Dr. Nelson Lau, CEO and founder of HealthBridge AI. So doctor burnout is a huge problem, and one of the main contributors to doctor burnout is administrative burden. And for every 1 hour that a doctor spends with a patient, they can spend up to 2 hours doing admin work. And this results in a huge amount of loss of efficiency and also mental and emotional and physical stress. So what's the solution? At HealthBridge AI, we've built Jarvis MD. So Jarvis MD is an audio-to-text transcription tool that saves a doctor from having to type during the consultation so they can focus more on the patients instead. And this can result in up to 70% savings in administrative time and also ends up reducing doctor burnout and improving patient satisfaction. What's unique about Jarvis MD is that we're using artificial clinical intelligence, and this is the summary note that's created, and this is what most AI scribes are creating through the audio transcription. So we're not like most AI scribes. So AI scribes like Epic Nuance, Abridge, and Heidi are working in this particular space. But with Jarvis MD, we're using artificial clinical intelligence to provide the doctor with clinical recommendations in the context of the patient that they've just seen to help remind them of potential differential diagnoses, management, and also investigations that they may not have considered during the consultation. On top of that, we also have an AI clinical co-pilot. And this co-pilot allows the doctor to ask complex clinical questions in the context of that patient and provides them with up-to-date, evidence-based and referenced answers. So what's the competition like? As you can see, it's pretty crowded. And I can go through this slide and just show you the differences between ourselves and our competitors. But I think what's more important is to understand the evolutionary roadmap of where AI scribes are now and where they're going. So you can see from the first generation here, this is where there are a large amount of AI scribes. But most of these AI scribes are tackling administrative tasks wrapped around something like ChatGPT, which makes them inaccurate and also unsuitable for clinical use. While they're at the first generation, we have already executed on second and third generation features for AI scribes, which include clinical decision support and also contextual clinical search. So despite hundreds of millions in funding, why are these other scribes still stuck in the first generation? Because moving from simple basic administrative tasks to working on the clinical intelligence sphere takes a lot of deep expertise in healthcare, AI, and also engineering. And we've executed on that to make sure that there's clinical accuracy and also patient safety as well. And we're not stopping at third generation. We're already working on fourth, fifth, and sixth generation, which is going to fundamentally transform the way that clinicians work. Our business model is a basic SaaS model, and we are a SaaS subscription model, and we cater for doctors, solo GPs, to clinics, all the way to hospitals as well. So the global market for Gen AI in healthcare is projected to be $26.8 billion by 2033. Our go-to-market strategy is to firstly leverage my experience and expertise and also the connections that I've had over 30 years working in Australia, and then expand to the Southeast Asian market, where we've made some very good connections through the Data Accelerator program. And then from a position of strength, we'll be moving towards the US market within 3 years. So what's been our progress after 13 weeks? So I'm pleased to report that we've actually gained a lot of traction in the last 13 weeks. Firstly, we've had a soft launch of Jarvis MD in November, and real doctors in Australia are using it with their patients. And we're getting fantastic feedback with that. We've also been in discussions with 3 of the Singapore cluster hospitals and 1 private health group as well, and talking about implementing short pilot programs where if we meet the success metrics, then potentially we can convert them into paying customers. We've also been in discussion with 1 Singapore hospital in utilising their genomic data set and collaborating to create a predictive tool that can be integrated into Jarvis MD, which can help in the prevention of early stroke. And lastly, we've got a partnership with IBM, where IBM has invested 6 of the developers to help integrate part of the IBM WatsonX.ai technology into Jarvis MD. And we've been working closely with their sales and distribution team to look at how we can push our solution through their distribution channels into the enterprise healthcare customers. So why are we well suited to succeed? Firstly, I've got over 30 years of clinical experience and also experience in digital health. And my co-founder has proven track record in scaling AI applications to over 17 million users. We've also got a very experienced team of medical specialists and also experienced entrepreneurs and world-class cybersecurity experts. So what's exciting for us now isn't where we are, it's where we're heading. And we're raising $1 million to help us launch in Australia and then expand into the Southeast Asian market. And what the funding is going to help us to do is to strengthen and accelerate our product development and also strengthen our market position. So what we're looking for is forward-thinking investors and healthcare providers to come and join us, because at HealthBridge AI, our mission is simple. By empowering doctors to focus on being doctors, everyone wins. I'm happy to show a live demo to anyone as well if they want to approach me afterwards. Okay, thank you.
Thank you, Nelson. I think we have about 4 minutes for questions. I think before anyone raises a question, please introduce yourself and your name and maybe your organization, so that I think Nelson have a bit of context, and then he'll be very happy to answer your question after. Yep. Does anyone have any questions?
Hello, I'm Kenny from the Rescue Tribe, and something that hasn't been really crossed over in the legal aspect of using Gen AI cross-referencing, right? Like, for instance, you're trying to have like a health policy or the latest literature on a particular disease, and now you are generating that or doing a web search, or does the doctor actually have to be logged in to say like a service like UpToDate, right? For it to be accurate and to have full full exposure to the entire piece, right? How do you handle that? Or is it just going to pop up stuff from the web and throw it up there?
Yeah, so there's three ways that we're approaching it. Firstly, it will be using reference sources from the web. Secondly, we're also looking at partnering with the potential customers to look at getting their own data sets as well and their own references. So in what we've been speaking of Singapore hospitals, for example, and they've got their own localized information that they want their doctors to reference to. And thirdly, we're looking at partnering with big partners similar to UpToDate. We're in discussions with them as well, where we actually use their database, and this is one of the largest medical journal publishers in the world, and using that as a source as well.
Yeah. So the actual question there is, would you run into a compliance issue if you are like putting up links for services that you don't that aren't paid for, but you're still using a paid product to put up those articles, right? In terms of your generation, would they come back to say, hey, legally we've been part of your product as well? Is that something you've foreseen?
Well, that's kind of like any sort of search engine, right? So any search engine, if it's not through a paywall, it's publicly available, right? So if it's through a paywall, then it actually won't you won't be able to access it. But we're looking at opportunities where we can partner with other companies like UpToDate, like Elsevier, for instance, where if the doctor is actually logged in, then they'll be able to access that as well. Yep.
I would like to understand Jarvis tool that you use for scribing patient notes and whatever it is from GP setups or hospital setups. Would they also do the coding? One for the ICD coding, and also for to the regulatory authorities worldwide, which use MEDRA coding for any events or drug issues?
Yes, great question, thank you. And so that's the coding is definitely on our roadmap. So as I was showing through the different generations, there's a lot of things to build, but that's definitely on our roadmap. And that again is going to be a task that'll help to reduce the administrative burden for the doctors. But thank you. Yep.
I think we have time for one last question.
That was a great presentation. In the product construct you have, how much is the product revenue and what's the services like when you think about this whole offering?
Sorry, how much is the product?
There's a product piece, and I believe there's more services. So how is the mix like from a product and services perspective when you build the product?
You mean in terms of the price plans, how much of it is how much are you paying for the product and how much are you paying for additional services?
Yes.
Okay, right. Okay, so at the moment we've got a flat subscription fee. I'm hoping that I'm understanding the question. But in future we're going to be having add-on products as well. So not every doctor is going to need to use every feature. And when we partner with other institutions as well, they can potentially add on features on top of that as well. But the main structure at the moment is a flat fee. Yep.
Okay, thank you so much. Thank Nelson for his time and his presentation. You guys can catch him later at the lunch for networking itself. I think we are going to go back to Singapore because I think we're going back to one of our founders here from Two Strands Biosciences. I think Deblina. I think she's been doing something amazing. I think very important to many of the clinicians we have here today.
Thank you. Good morning, everyone. I'm really excited to share the vision behind Two Strands with you today. We are on a mission to transform the way cancer recurrence is detected with an accurate yet affordable blood test. 10 million people die of cancer every year. Most of these deaths are due to recurrence. Today, about 50 million people are living in this world with a diagnosis of cancer and a shadow of uncertainty, of not knowing if and when their disease is going to come back. This uncertainty stems from the way we detect cancer today via radiological imaging. We are detecting cancer quite late, when the tumor is already between 1 and 10 millimeter in size. Can we detect it earlier to give patients that critical time window to fight the aggressive disease better? The answer is yes. The future of recurrence monitoring is an amazing innovation, ctDNA-based blood tests. Cancer cells shed short fragments of DNA into a patient's blood, and this is called circulating tumor DNA or ctDNA. Detecting ctDNA can detect recurrence almost up to a year before imaging can. But it's technically challenging because ctDNA is extremely scarce. It's like finding a needle in a haystack. And that's why the current technologies are expensive and they have limited sensitivity. At Two Strands, we are determined to solve this problem with an accurate yet affordable test. How are we achieving it? The breakthrough lies in our powerful target enrichment technology, which allows us to achieve exceptional signal-to-noise ratio. And bringing you back to the needle in the haystack analogy, what our technology allows us to do is to remove the haystack so that we can find that needle faster and with fewer resources. I mentioned that the current technologies, the clinically approved tests, have limited sensitivity and are expensive. So here they're in the bottom left quadrant. There are next-gen technologies which have solved the sensitivity problem, but they remain expensive and inaccessible to millions of people. There is a gap in the market for an accurate yet affordable test, and that is exactly what the Two Strands technology allows us to achieve. Upon development, we aim to be 10x more accurate and affordable and turn around 5 times faster compared to the current clinically approved tests. And we would be effective across a broader range of cancer types due to our increased accuracy. I don't have to convince any one of you that the cancer detection or the cancer diagnostic market is massive. The MRD market within that is already above $1 billion, and this is only the beginning. With newer innovation, clinical data coming in, regulatory approvals, and insurance approvals, this number is expected to go up to $22 billion TAM just for the top 4 solid tumors. Although our technology is applicable across several cancer types, we will first focus on lung and breast. And just for these 2 cancer types, the annual market opportunity for our test is estimated to be about $9 billion. To achieve this, we have a clear pathway laid out from R&D to preclinical to clinical. Each step we will build on the previous and demonstrate the value and clinical impact of our technology at every step. I know this is a busy slide, but I want you to focus on the first the clinical validity milestone. Once we hit this milestone, we will have a research use only product, and this will be our first exit/revenue opportunity. Once we hit the clinical utility milestone, we will have a diagnostic product, and this will be the more lucrative exit opportunity for us. The research use product can be directly marketed to biotech and pharma that are developing oncology drugs, and just recently FDA came out with guidelines as to how to use ctDNA for early oncology drug development, clarifying that business case. The diagnostic product can be marketed to healthcare providers via partnership with existing central laboratories who have the distribution channels already established. These products, together with our portfolio of IP, would be a great acquisition opportunity for larger genomics and diagnostic companies. So we will start by bringing value to biotech and pharma sector and then extend to healthcare providers and insurers. But at the center of what we do are patients, helping them navigate their treatment journey with greater certainty and better outcome. We have an experienced team. I am a cancer and molecular biologist for over 11 years now. We are already working with several world-class organizations to bring this mission to life. Now we need your help. We are seeking $1 million in capital investment to achieve our next innovation milestone. Please come and join us at Two Strands to redefine the treatment journey and outcome for millions of cancer patients. Thanks for your attention.
Thank you so much, Deblina. Okay, do we have any questions from the audience? Yes, I think we do.
For context, my name's Kenneth from Johnson & Johnson, JLab Singapore. First question is, can you send me your non-confidential deck? And then second question is...
Yes, the answer is yes. Yeah.
When you deploy this clinically eventually, are you thinking in terms of like, is this going to be an IVD test? Is this going to be LDT? What are your thoughts on that?
It's a great question. We have both those sort of paths open to us. Most of the current players are LDTs. So if you're aware of Guardant Foundation, so they are LDTs. But currently, going forward, FDA wants more purview of LDT. So it's a little bit murky, that road. Although, as far as I'm aware, they are not asking for too much. You have to essentially report at adverse events, which with diagnostics, that is not a major problem. So we are right now considering both opportunities. But I do think LDT might still be the easier path to take eventually.
It'll be easier to market, but harder to scale. But that's something to think about.
That's something to think about, yes. We are considering both, yeah.
Okay, any other questions for Deblina? Oh, okay, we have a few. One there and one there.
Good morning. My name is Jeremy. I'm a venture capitalist. I have my own fund, Genesis Alternative Ventures. And before starting my own fund, actually I was with EDB Investments, looking at medical diagnostics. So on this journey itself, how much funding do you think you are required to take it to at least an investigative or a full product?
So we, for the pre-seed, we are currently here. We have completed our, We've completed our MVP. To get to feasibility, product development and feasibility, and partially through to starting the clinical validity, we're looking for $1 million in pre-seed. And this will be sort of supplemented with, at least in our plan, it's to be supplemented with government grants that are out there and with our collaborators, since we are kind of trying to already set up collaborations with GIS, we're trying to set up collaborations, or we've signed MOUs and are negotiating RCAs with NCCS. So there can be grants that we will be supplementing that process through. We expect to go complete the validity and reach about a part of the utility with the next round, which is seed, which is going to be anywhere between 10 to 15 million. But to complete the utility completely, we would have to raise a seed round, which I wouldn't want to preempt too early right now what the value of that would be.
I think we have one question there from...
Hello, I'm Wonjae from South Korea. I'm a cardiologist. So is there a particular reason why you're only focusing on recurrence? Because like Korean market, we are doing more and more health checkups, and it's much easier to package them into this kind of package. So I want to know, why is it tech or is a particular reason for it?
No. So the tech, actually, there's nothing stopping us from developing the tech for multiple applications, to be honest. At the core of the technology is improving genotyping. We are trying to make genotyping more efficient with an NGS-based approach. And any application that requires a more efficient genotyping can be used for this tech. So obviously the low-hanging fruits that we always kind of get asked is, why aren't you looking at early detection? The answer is no one's stopping us from looking at it. We just think that the recurrence market is a lot more defined than the early detection market. And you've seen that from examples like just take Grail versus Natera. Natera doing really so much better, year-on-year revenue growing, whereas kind of we've seen the story with Grail. So I think business-wise right now the market is more ready for recurrence. Early detection may happen in 5 years' time. We would have the technology to pivot then. Another low-hanging fruit, of course, is target selection. There are established products out there, but we could probably come in as well quite easily there. We can expand beyond oncology eventually into anything that requires DNA alteration-based detection. So that's always a possibility.
Okay, thank you. I think we've run out of time, but I think we are very amazed by what Deblina has created. So if anyone want to catch her after to kind of speak to her, and of course she has a deck readily available for all of you, please don't hesitate to contact her. Okay, so from cancer, now we are going to heart health. I think I'm very pleased to kind of introduce the next startup, which is HealthBeta. Please, Prof. Heng.
Once upon a time, when someone collapsed because of a heart disease, the gurus will say it's because of the positions of the stars above. But in recent years, we have understood a lot about the underlying risk factors for heart attacks. But then, if you look at the statistics today, it is still the #1 killer in most developed countries. And in Singapore, it's the #2 or #3, depending on which year you're looking at. And every 1 in 5 deaths in Singapore is due to heart disease. Good morning, I'm Chu Kiat, and this is KUN. We are the co-founders of HealthBeta, which is a company that's focused on addressing the unmet needs of coronary artery disease, which is essentially blockage of the heart arteries. Now, there are many challenges. How early can we detect individuals at high risk of heart disease? As with all diseases like cancer and so on, the earlier you detect, the better it is. And for people with, let's say, high risk factors like LDL cholesterol, every year that you delay intervention increases the risk by 5%. So if you don't do anything for 10 years, you increase it by 50%. So how can we push the timeline of the detection as early as possible? With genomics, we can in fact push the timeline all the way to the day at birth and identify who are the babies who are at high risk of a heart attack. Now, in the community, right, how do we know which individuals are at high risk? Well, we can say, oh, do a cholesterol test, which is very common today, but 50% of the patients with artery blockage have ideal levels of cholesterol. So using a single biomarker like cholesterol is not good enough. And then when one has got high risk factors, I mean, the doctors will say, okay, you got to eat healthily, stop smoking, exercise regularly. But exactly, it's easier said than done, right? How do you know, am I really eating healthily? Is one bowl of laksa too much once a month? Is it unhealthy, right? And for those who are unfortunate to get a first heart attack, how can we prevent the second one from happening? Because the second one can be a lot more severe and it can be fatal. I'm a genetics researcher, so I can tell you, genes can account for up to 60% of a person's heart disease risk. But with today's technology, it's not easily corrected, okay? But having high risk based on genetic testing is not a death sentence, because we know that the good news is genetic risk can be mitigated by changing lifestyles. I mean, this has been proven in a very large studies in the US, in which the relative risk can be decreased by 50% just by correcting lifestyle. So no need to correct the genes, just correct the lifestyle. So at the heart of HealthBeta's product is the Enhanced Polygenic Risk Score, or EPRS. So we leverage on genomics to predict risks of heart disease, but to enhance that, we actually included lifestyle risk factors as well, to increase the sensitivity to above 90%. And it is with this knowledge that we can drive the lifestyle intervention efforts to address the specific needs of each patient. So as a researcher, of course, I derive great satisfaction seeing that my papers can be published in journals, but then in journals, only the researchers read about it. So the real benefit is actually to bring this product out to patients who can really benefit from it, and that's where I get my most fulfillment. So EPRS at the core of the technology, and then driving all the rest of the lifestyle intervention, and that's what our product is all about. And
to address those who already have a heart attack, we have an ongoing study now based on our SCAT-Gen study to really push the boundary of the EPRS to not just detect risk in the community, but to identify who are the heart attack patients who may get a second heart attack. And for those who are at high risk, we can then increase or step up the care that's provided for them. And now over to Kieran.
Thank you, Prof. From health economic analysis, we discovered that a young heart patient can avoid 300,000 of productivity loss if he can avoid a CAD event. From a healthcare provider point of view, they can generate $6,000 of gross profit from every case they handle by reimbursement from insurance using identified CPT codes. The same healthcare provider also can break even from their operations merely to take in 65 cases a year. Under an insurance scheme that covers 3,000 policyholders, an insurer can avoid $36 million of insurance claim by reducing CAD cases. The total addressable market for CAD prevention using EPRS is $400 billion globally. Our launch market is to acquire 5 health systems as our customers, which would generate us $2.5 million in the first year of our launch. Looking at the competitors, potential competitors, Health Data is positioned in an advantage position in terms of our personalized prevention using genomics and our ability to produce very targeted lifestyle intervention recommendations. It's very fortunate to have opportunity to team up with Prof. Heng. Prof. Heng is also an associate dean of this school of Yong Lu Lin of medicine here. I'm a second-time MedTech venture co-founder. Before this, I worked for an IoT department of a multinational. Our very next milestone is first to launch product to the market by completing our product development and to clear regulatory, medical regulatory by HSA and FDA. Second is to expand the market to the US by establishing collaboration in US for prevent against studies and pilot programs. We are raising $1.5 million for this. If you have interest in CAD prevention using EPRS, we are happy to elaborate more. Thank you for your attention.
Thank you, Kai, and thank you, Prof. Heng. Does anyone have any questions for the two lovely founders? Okay, we have one there. Patrick.
I do have a few questions, but for this session, I'll probably ask one. I saved it for others. Now, you did mention in one of your slides, right, that genes contributes about 60% to how to identify a risk. So I'm trying to reconcile in terms of, because there is also mentioned that lifestyle change can actually mitigate the risk to more than 50%. Can you elaborate a little bit more on this?
Oh, that's an excellent question, but with 1 minute, I don't think I can have an excellent answer for you. Okay, so the way we look at it is not simply compartmentalizing genes 60%, so environmental 40%. What most people are missing out is this intersection of gene interacting with the environment. So we have to understand that the unfavorable genes may be there, but if the environmental trigger is not there, then the risk is not there. I mean, as geneticists would put it, nature loads the gun and environmental factors pulls the trigger, right? So in my own studies, I have a gene that predisposes people to higher risk if they smoke. But in the presence of that so-called bad genes, right, if that person doesn't smoke, then the risk is not there. Yeah, I hope that explains.
Hi, Sebastian Ester. So is it just PRS-based or PRS plus the classical cholesterol BMI?
Yeah, PRS plus lifestyles. Because PRS, like I mentioned, only explain up to about 60%. Yes. We need the rest of the lifestyle factors to give a more accurate prediction.
So my question then is also, because you have with the local study, you get a much more custom, better PRS score for here. But when you do the market expansion, are you gonna adjust it with the other markets?
Oh yeah, definitely. Especially with genomics, because the allele frequencies in different population is different. So if we train this in the Asian population, we'll need to tweak the coefficients of all those genes in other populations.
You may be interested, we have a homomorphic encryption benchmark to compare attract and Singhart cohorts on the PRS scores, and we are working on doing this cross-border with HDR UK as well. Right. So we can possibly help you compare to other international cohorts your score or develop your market-specific score.
Certainly, I'd love to speak to you after this.
Okay, I think we have one more question. I think Adeline.
Hi, I'm Adeline from Essilor-Luxottica. So I'm going to come from a very consumer angle. So as a user, in order for your product to work, I need to be compliant, right? To put in the data, to say how many bowls of laksa I ate. Yeah. And there is also a combination of behavioral nudge or changes that needs to come in. So what is the assumption that, the success rate that I will 100% comply and do it versus like maybe only 20%, which is the reality?
Again, another excellent question. I don't think realistically anyone can achieve 100% compliance, because compliance is really about, up here, I mean the motivation and behavioral as well. So what we are trying to do is to reduce the hurdles, right? If I ask you to recall and jot down in your journal what you ate for breakfast, for lunch, for dinner, you're probably going to give up. But if the mobile phone can take a picture and understand this is roti prata, and at lunch this is chai fan, evening this is spaghetti, and calculates the value of the nutrition, then it makes it a lot easier and there'll be less so-called non-compliance. We're trying to reduce that hurdle, the hassle of logging your activities and your meals.
Yeah, I think this is only step one. Then the second step is the behavioral change, right? To encourage us to change our lifestyle. So I think that piece is kind of missing. Like, how do we do the nudging?
Yep. So our partners has got nutritionists and also physical trainer involved. So we'll actually engage them in terms of nudging such behavioral change.
Okay, thank you so much for your questions, and thank you Health Beta for the wonderful presentation. Okay, we are going to our last startup. I'm very proud of them because I think they are Marymount Labs. They are the startup that actually originated from Health Hack. They come a long way since the start of January. I think both me and Paul saw their first presentation. I think some of you who actually attended Health Hack are here in the audience. So do take a look and see how they have progressed and grown since their time in the Accelerator.
Hi everyone. I'm Zach, the co-founder of Marymount Labs. So ask a doctor today to comb through hundreds of pages of healthcare policy to figure out the best course of care for that patient in a short span of 15 minutes. It's impossible. But this is the state of healthcare financing policy today. The outcome? Poorer patient care and missed revenue opportunities. Take Healthier SG, for example. This is Singapore's national preventive care strategy aimed to incentivize GP doctors to prioritize their patients' preventive and chronic care. So in an ideal world, these patients will go for their regularly scheduled vaccinations, early cancer screening, and lab tests for their chronic diseases. These diseases are then detected early or prevented entirely. But why does this not occur? One major reason is that GP doctors themselves do not fully understand the rules. They do not understand what the annual service requirements for each patient are. So for every patient, they may have a different chronic disease profile that results in different inclusions and exclusions to the annual service fee requirements. And what does this mean for the GP doctor who does not have the time to look through these rules? For GP doctors, this could mean missing $100 per patient on average. But the real tragedy here is that 80% of patients miss out on their annual service requirements. And what that translates into is missed critical vaccinations, potentially life-saving cancer screening, and facing unmitigated chronic diseases. So the policy is well-intentioned, but the sheer complexity of these financing policies means that healthcare providers are swamped and confused. So solving this problem requires us to understand two challenges. One, healthcare policy is inherently complex, And number two, clinical data is messy and inconsistent. Without bridging these two challenges, care gaps go unnoticed and revenue is lost. Solving this requires us to decode healthcare financing policy and applying them to clinical data. This is why we built OpenGP. Using our custom models, we are able to infer relationships, extract rules with a high degree of accuracy, and apply them directly to clinical data. This helps GP clinics uncover their care gaps, drive revenue, and most importantly, prioritize patients' preventive and chronic care. With OpenGP, we have helped this small GP clinic identify and close $6,200 worth of care gaps in less than 1 month. And this isn't just about revenue. These patients were able to go for their chronic disease consultations and receive ancillary care services. And while we helped this clinic see a 1.5 times boost in their earnings in under a month, $20,000 of additional care gaps remain untapped. Therefore, we believe that OpenGP is able to help policies like Healthier SG achieve their intended policy outcomes. Now, the success we saw with this one GP clinic isn't an anomaly. We worked with 34 GP clinics in the past 2 months to help them decode healthcare policy, uncover their care gaps, drive revenue, and improve patient outcomes. In Singapore, the market opportunity or the fundable gap that exists is $55 million. This is across 1,000 Healthier SG enrolled clinics. We are able to do this because of our team's unique skill sets. My co-founder has a background in helping UK biotech startups develop their clinical grant studies and has also published in top biomedical and deep learning journals. My background is in data engineering at a Bay Area startup, where I helped them develop big data pipelines for the financial industry, another highly regulated space, and with quite similar challenges to what we see with healthcare data today. With Healthier SG, we have proven that our technology can decode healthcare policy complexity. But primary care in Singapore is only our beachhead market. What we realize is that the greatest market opportunity is actually where these policy documents are the most tedious, the most laborious, the most complex. In Singapore, for private insurance for specialist care, healthcare financing is particularly complex. So just take a simple colonoscopy procedure, for example. Just figuring out whether it is covered, just figuring out what the deductibles and co-pays are, could take days of manual verification. And in the US, we have complex risk-sharing models under the accountable care organizations. We have private insurance, and we have risk-bearing entities where our software will be highly relevant. We are raising a seed round next year to enter the specialist care and the US market. If you're a primary care provider or specialist care provider, we would love to speak with you to see how we can tackle this complexity together. So let's make healthcare policy not work just for the policymakers and the insurers, but also for the healthcare providers and the patients. Thank you.
Thank you, Zach and Les. If you cannot already tell, they are both brothers, amazing brothers together. If you all have any questions, please, we are very happy to take it. And
good morning. So my name is Marshall from Novo Nordisk. I mean, since you use diabetes as a use case, I think I'm obliged to say something. So because we know that Healthier SG, for example, is a policy launched by the government, and the government does have a lot of inroads into smart CMS and basically getting the tech providers to facilitate this flow of funds. So basically, if something was rolled out by the government through the CMS, your solutions are sort of taking a backseat. So are there any insights that probably the CMS providers are not doing that, and hence your solution will sustain the market for a longer period of time, or it's just technologically impossible for them to go to that area?
It's not technologically impossible. CMS, I mean, depending on which of the 20 CMS providers there are in the primary care space today, they have a different approach, different strategy in the market. It's not technically impossible, but it's technically very difficult to decode and understand policy and translate that into business logic and apply into their clinical data. It's technically difficult for one reason, because the frequency of policy updates, the unpredictability of when some of these policies can be tweaked. And we're just talking about healthcare SG here. There are various policies other than healthcare SG in the primary care space. There's also how it interfaces with private insurance schemes. And so with all of that at play, it becomes quite challenging, I would say a monster to tackle within the CMS. And that's not the core business of CMS providers anyway. So they may not be looking at it as a first move. So there needs to be a distinct category of software products like ours to decode policy complexity. But of course, primary care is not just, it's just our beach-shaped market. We are much more interested in the wider complexities that exist in specialists and insurance. Thank you.
Thank you. Anyone else have any questions for Marymount Labs?
Hey, I'm Kenny. I really liked your presentation. I do feel like I have the unique privilege of working in two healthcare ecosystems. I trained in India as a doctor and moved here. I am still currently a doctor as well. I do think that there is this innate culture in Singapore that exists where we promote testing, even in events where it's going to basically protect ourselves, not necessarily for the patient. And I do feel like, would you comment, or would you say if this adds to that, if we are purposing it in terms of increasing revenue, right? As opposed to primarily, if your pitch deck said, hey, the patient is at the core, these were missed, like, are GPs actually underdiagnosing, or by not picking up on these cues, by not running these tests, or is this going to promote a culture of over-testing?
I mean, I can start. So I think at the core of it, we believe that healthcare policy is always well-intentioned. And I think that is particularly the case with healthcare SG, where we see that many chronic diseases go undetected. And with the right test, they definitely can be prevented entirely. But why patients are not going for these tests? We realize that if the GP doctors themselves are able to encourage them, provide them with the correct advice, they would likely take these tests, and their conditions will go detected. So I think the gap here is really in translating these policy incentives into actionable decisions on a clinical operations level.
Yeah, I want to just echo that point about easy nudging and how effective that is once the provider is able to understand what the patient needs. Last night we sent out a batch of messages on behalf of a clinic to encourage their diabetic patients to go for DFS-DRP. And within a few hours, actually, when we last checked, we about 10% reply and said, yeah, I'm willing to go for it. And maybe, just maybe for this group of patients that so readily agreed, maybe we catch something, maybe we prevent something from progressing. Healthcare policy is always well-intentioned, but we want to help with the implementation.
Okay, I think we have done with questions. I think please thank Marymount Labs for their presentation. I'm very, very proud of them and very amazed how they kind of progressed. I think many of you who were there for Health Hack, you saw how they progressed and evolved over time in their progress. Thank you all so much for spending the Saturday with us. I hope we didn't waste your time. I hope you really enjoy yourself and learn more about the ecosystem, more about new innovation in medical technology. I just want to kind of highlight, so I think Marymount Labs actually originated from a hackathon last year, Health Hack 2024. We are actually doing our next iteration next year, Health Hack 2025. And I think we got like greater interest and sponsors as well. So we are actually doing it both in Singapore and Indonesia, both sometime in February. The website is actually really up for Health Hack. I think we did like little to no marketing, and I think we like about 70 participants have signed up already. So it's quite crazy. If you do know anyone or anyone in your organization that's keen, as you can see, there's so much need to kind of for more medical innovation and to grow the ecosystem. So please scan the QR code. If you have any questions, you can contact me as well. I think I LinkedIn bombed many of you. So thank you all for coming. Thank you.